of patients and the severity of the illnesses are not yet that many for us, and the resources are many pa naman. So the resources are greater than the number affected. So life-threatening injuries or illnesses are treated first, just like how patients are brought to the hospital. Pag konti lang naman yung pasyente or hindi ganun kadami hindi ganun ka-severe yung kanyang situation, then it is a one-on-one. We treat the individual patients first. However, if the number of patients and severity of the illness are now outweighing the number of resources we have, then the patients with the greatest chance of survival are treated first. So this is where the concept of triage comes in. So for emergencies, we do the best for each individual, but for disasters, we have to understand the ethical issues as well here, that the greatest good for the greatest number of people prevail. So looking further at why emergency medicine should be involved. So we see here in this framework or in this illustration that there's a lot, since most of our participants perhaps are, if I'm not say all, no, of our participants are all working in emergency departments or in disaster DRRMs, and in general in the PMA chapter, in general, all of us are really in the front lines, working in the front lines for medicine in the future. We may be called on to take on that duty. So we have to look at the framework that we have to be prepared all the time for disasters, and we need to look at the resilience as well of our workforce and our hospitals as well. So here we need to understand medical continuity and surge capacity, and emergency medicine is part of this framework. And in the future topics, after this introduction, we will hear about what an incident command system is. We will talk about mass casualty incidents and surge capacity, logical first aid and network, and that's to get to look at the of care between. So again, I'd like to commend the efforts to all of our colleagues are present here, and that most people here are actually also emergency medicine business. So, namin tanong sa sarili natin, kami, doktor lang tayo, clinician lang tayo, ba't ba tayo makikialam? We really cannot forgo not talking about all of these things, because we should
Recording in progress.
then that defines also the capability of the entire healthcare system. Unfortunately, it takes a long time, no, for us to be understood. So be prepared to be misunderstood for a very long time. These are concepts that are very difficult to grasp. And even us, we have a long fight, no, to make it understood that emergency care should be actually part of universal healthcare. And it was only in 2019, just a few months before the pandemic actually hit, that nilabas ni World Health Assembly, no, that emergency care system for universal healthcare coverage is making everybody understand that emergency care is universal healthcare, and we need to ensure timely care for the acutely ill and injured. And in fact, most of us, when shown this spectrum, it's easy to understand. However, difficult to implement. So it cannot easily be implemented, because it really takes a system to save lives. So when you look at this framework, it's easily understood that we need to connect the dots. So even before a disaster happens, we need to look at the neglected disaster, which is emergency care. And this is looking at it at a continuum, no? As a continuum, and it's a system. It's not just about acute care na isa-isa lang. So if you look at this, there's care for the pre-hospital. That's where immediate first care is done, immediate emergency care is done. Even in transit, care should be continued until the patient is received in the nearest emergency unit, and it's part of our advocacy. We are not just a room. We have stopped calling ourselves an ER, and we are not ER med. We are emergency medicine. So we call ourselves, if we work in an emergency department or emergency unit, if the patient needs to be admitted, then we may take that patient inside our hospital. But if the patient may be needing other care or definitive care, then we need to transfer, which now brings another element here of an interfacility transfer to another hospital. Of course, you can discharge your patient anytime if the patient is improved. So if you look at all of these things, you can see a lot of circles, and these circles have lots of dynamics as well as to triaging. So siguro, moving on to the last concept that I will need to share. This is about fixing our ecosystem, and ecosystem here means emergency, critical, and operative care before, again, disaster strikes. So we need to be very inclusive, and we need to empower our healthcare providers. We need to ensure equitable and timely access of emergency care, and ensure safe, high quality, effective healthcare in general. So when you look at this framework, you look at this also in the continuum that these are our everyday health systems. We really acknowledge and recognize the efforts of our primary care providers. So all those doctors here working in preventive, community, and primary care, all of our clinicians, we are all here. However, if there are patients who are para maging emergency, so at any point in their life, there always comes a point when a patient may need emergency care and critical care at some point. So we need to strengthen also as well emergency and critical care and even operative care. So this is where ecosystem is the part of that healthcare system that may fall into the cracks of not, they do not improve. Even with our conscientious and our unconscientious care, even if we've given them all that we can, they may fall into their natural course of the disease or their illnesses, that they may be needing emergency, critical, and operative care. But mind you, these are just everyday health systems. When a mass casualty happens, and one of our speakers will talk on this some more, there's mass casualty management as well. So just remember that this is the very thin line that defines now emergency daily care and that of an impending disaster of which we are very much overwhelmed. And look at this conceptual illustration. WHO did not put here specifically disaster because it's altogether a different topic. But if you are not, it's always been a mantra among us, if we cannot cope with our daily emergencies, then how can we cope when there is a disaster? So we look at our surge preparedness. Our president later will talk about our surge capacities. And we look at our response also, and how we will prepare really for emergency care, daily emergencies in our healthcare system. So with that, maybe my last message is that we have to be prepared early for, and that we have to be equipped. We have to be capable of providing basic emergency care at the very least, and that timely care saves lives. And as part of promotion, I'd like to invite everyone to ISEM 2024. This will be in June 19 to 23 in Taipei, Taiwan. And lastly, perhaps my message is, let's all be kind. And don't forget to take care of yourselves. We need to take care of others. Thank you very much once again, and thank you especially to Dr. Ray Ponteras. If you need email or contact me at any point, posted is my correspondence.
Pauline, thank you very much. Dr. Kolokar, I know that you are quite a busy person. Little did you know that Pauline also is a Mindanaoan, just like us. So she clearly understands our struggles in terms of disaster and emergency response. So how did you manage to get out there alive?
Wait lang, Dr. Ray, I missed the question. What was the question? You are muted, Dr. Ray. What was the question?
No, I'm not. Uh, wow. I was
Yeah.
asking, how was Ukraine? How did you manage to get out alive?
Oh, yes. Thank you so much for the question. Actually, it's not a very top secret. It's not a very top secret mission, but I was sent there
Mm.
for training. Actually, they called me and asked me if I can give them training on emergency care. And it is a bit, ano naman, there are a lot of air raids, but there was the air raid is insured by UN. So, okay naman yung they guided all of our travels and our movements to their security. Thank you for the question, Dr.
Thank you. Thank you for your hard work, Pauline, and for serving the humanity. Neighboring countries, especially around the Ring of Fire.
The question, Dr. Ray, is about countries around the Ring of Fire, but I missed the first part.
Sorry about that. I was asking, how does the World Health Organization view the Philippines in terms of preparedness to disaster and emergencies,
Yes.
comparing us
Sir, the world really sees Philippines as one of the stronger countries when it comes to disaster preparedness. And it's very, very evident with our framework. They look at our legislative framework. We're very pero
Recording in
mahirap tayo
progress.
sa implementation. But on a bit on the lighter side of it, we're very resilient as a people. But in truth, it is also one of our weak points when we say, you're resilient. Parang I cannot say that hindi pwede kasing sabi how does WHO looks at the Philippines, but more of how do other countries see us as a country, as a people.
Recording in
Earlier
progress.
shared, medyo dun tayo namomroblema sa daily emergency cares natin, the patient navigation, where patients will go when they seek care. That's our ano, I think, our weakness. But when it comes to strength as for disasters, we're actually topmost on the list of the other countries. They look up to us.
Thank you, Dr. Pauline. The reason why I asked that question is that here in Mindanao, we are trying to be resilient in terms of disaster response. You were showing a while ago the ecosystem for emergency response. And with the 4 rings, the pre-hospital care, we took care of that just last month in February with the launching of our AED Ready Johnson initiative with the Dadiangas Medical Center. The aim of which was actually to increase public access to
I'm not sure if it's
answer
me.
and to take care of the most time crucial uh, part of the chain, no? The first ring there, which is the community response to emergency. So hopefully we move forward down the line and improve our dispatch system, the ambulance actually, responding to, after the community has responded, the good CPR, use the AEDs, send off the ambulance for dispatch, and then for definitive care in the hospitals, whether to admit or to transfer a more capable hospital. So we still have a long way to go, and with your help from our friends and colleagues in Manila, then probably soon. So any questions from the floor? Did we gather some of those questions? Or anyone wants to ask this question, you are free to do so. Kindly raise your hand and we can you can just unmute. Chat room. Okay, we have one question here from Jonathan Villano. Good day. What is your assessment and specific observation on the challenges on disaster management of LGU Jensen? What are the immediate recommended steps needed? Mr. Villano, we will have a speaker later this afternoon, Dr. Bong Serra, our own Dream O officer. He will probably address this when during his turn, when he will be doing the talk on disaster networking. If you notice the trend of our topics, we started off with the basic knowledge on disaster and emergency preparedness, moving on to our hospital response with surge capacity, MCI, incident command system, and slowly going out, moving towards business continuity planning, psychological first aid, and down to the disaster networking. We will do this topic later at 3 o'clock in the afternoon. So, okay, we'll ask Dr. De Serra again. Kindly remind me, Mr. Villan. Okay. Any other questions? I think it Wilma may nakuha. Wala lang. Okay, so I think that's it, Pauline. Thank you very much for your time. I know you are very busy, and she's an epitome of a strong, empowered woman.
Grabe, Dr.
Okay, I always
Ako.
admire Pauline for her dedication. Okay, with
No,
that, let
thank
me
you.
present to you the certificate of appreciation. Virtual muna pa ako. I'll just send this over to you. So let me read the citations. Dadiangas Medical Center, your trusted health partner, in partnerships with the Philippine Medical Association, GSCCI chapter, and the Philippine College of Emergency Medicine, presents a certificate of appreciation to Dr. Pauline F. Convocar for her valuable contribution as a speaker on Introduction to Disaster Medicine in the Scientific Symposium on Disaster and Emergency Preparedness, given this day, the second day of April 2024 at the Dadiangas Medical Center, Conference Hall, Leado Street, City Heights, City of General Santos. Signed by our Medical Director, Dr. Eva Badayas Formigos, and the PMA President, Dr. Japit O. Gallagher. So, okay. So that's it. Thank you, Pauline. And we hope to see more of you in the coming days. And again, thank you for helping me organize this beautiful symposium, which is really timely. This should have been done last year. Actually, naunahan kami ng malakas na lindol. So we are still on time. Hopefully, no more of that. But again, thank you very much, Pauline. If you can stay around, so if you want, and then I'll just call you later. Okay. So we'll move on to the next speaker. Okay, we'll move on to the next speaker. He had his training in science in biology at De La Salle University in Dasmariñas, Cavite. He's a doctor of medicine of De La Salle Medical and Dasmariñas, Cavite, and he finished his Masters of Hospital Administration, College of Public Health, University of the Philippines. He is a emergency medicine specialist of Hospital ng Makati, a fellow of the Philippine College of Emergency Medicine, a diplomate of the Philippine Board of Emergency Medicine. He served as a chief president, Department of Emergency Medicine, Pre-Hospital and Disaster and Ambulatory Care. And also he became the president of the Philippine Association of Residents in Emergency Medicine. Swing Cross Center. He's trained in management systems, then command system, where he is considered as a cadre, the highest in terms of leveling as expert on a subject matter for ICS or next.
Recording in
Without
progress.
further ado, help me welcome our next speaker to talk about Incident Command System, Dr. Daniel Valdemar V. Carpio. Dr. Dan. Dr. Dan. Yeah. Can you hear me? Yeah. Okay. Good. Can you hear me? Dr. Dan. Dr. Dan. Kindly unmute. I think nakamute ka. Ladies and gentlemen at the audience, we'll just allow Dr. Dankar to fix the audio first. Nice once again our sponsors for today, United Laboratories and the One Alpha Network. And also we are joined by our partner, a main sponsor for today's event is the Philippine Medical Association GSCCI chapter with Dr. Japit Galagaran as the president. Thank you to the officers and members of PMA Jensen. We are also joined by the Philippine College of Emergency Medicine with the president who will be talking later, Dr. Jeremy Cordero, and the president of the Asian Society for Emergency Medicine, Dr. Pauline Convocar, who's with us. Also present here on site are our founders, Doctors Jerry and Fer Rafael, Dr. Cesar Anthony Yawat, our president, Dr. Yasmin Babar, and our very lovely guest, Dr. Dulce Section Kabatay, and Dr. James Manching on the other side, and also representatives from the different hospitals around Jensen. I saw people from Sargent County, from MMC. Sino pa hindi ko na see? And also the members of the staff, the active staff, and the employees of the Jangas Medical Center. Okay, so as an overview of our topics for today, we started off again with the basics on disaster medicine. It was done by Dr. Pauline Convocar. We'll move on with the incident command system, followed by the mass casualty incident response, and then the surge capacity. And then this afternoon, we'll start with the business continuity plan and the psychological first aid. And finally, we'll have a speaker to talk about disaster network. So if there are questions that we cannot pick up, probably from the chat box, we will flash later our official email address for the symposium, or you can email us or use the number that we posted on our Facebook account for your questions, and we'll get back to you. Dr. Dan Carpio, are you? Apologies, we are still experiencing some difficulties with the audio system of our next speaker. As of 9:30, we have participants from Stock County Hospital, Mindanao Medical Center Incorporated, Lemniscate Data ITS, Johnson Doctors Hospital Incorporated, Dr. George P. Royeca City Hospital, Socopa Security Agency Incorporated, PNP Health Service, LGU Javier, Socopa Security Agency Incorporated, the Philippine Red Cross Johnson Chapter, LGU Javier MDRRM Office, Philippine National Police Health Service, General Santos City Water District, Philippine National Police, PMA Jensen, BSM Realty Corporation, DAP-MC, Labelia Hospital, RO Diagan Cooperative Hospital, RODCH, South Cotabato Medical Society, Bicol Medical Center, PNP General Hospital, Mindanao Medical Center Incorporated, and
Meron akong video. Sorry. Hello, Doc. Good morning.
Okay. Good morning, Francis.
Yes, po.
Okay, so we'll just move on to your topic while we're waiting for Dr. Dan Carpy to fix the technical
Sure, po.
issues.
No problem.
So let me introduce our next topic speaker on mass casualty incident response. He's a graduate of Medical Technology from San Pedro College in Davao City. He had a postgraduate training at medical degree, Davao Medical School Foundation. He's also a member of the Department of Pediatrics, Brokenshire Medical Center, Davao City, a fellow of the Philippine Society of Medical Specialists in Government Service. He's also a facilitator of BLS training of trainers, or TOT, and mass casualty management. Currently, he is a faculty member of Davao Medical School Foundation. He's also a visiting physician, Good Shepherd Hospital. He's a clinician of MDMRC, a retainer physician of Bunawan Medical Specialists Incorporated, and a medical officer core of SPMC Davao, and a member of Watershed
Dr.
Management Council of Davao City.
Enough na
Ladies
po.
and gentlemen, let us all welcome Dr. Francis Porticos, MD, to talk about mass casualty incident response. Franz,
Okay.
the stage is yours.
Share. Pila to. Yung video na ko. Okay. Ano naman siya dito start? Stop share. Good morning, everyone. May I ask if I am loud and clear po? Can anyone
Loud
hear
and
me?
clear, Dr. Francis. We can also see your slide.
Thank you. And the slide is already shown na rin po.
Yes, we can
Thank
see
you
this.
very much. Thank you very much, Dr. Ray. So we'll proceed with the mass casualty management. So I will be your speaker for today. I am from the Health Emergency Management, Disaster Management Unit from the Southern Philippines Medical Center. Next slide. So these are my disclosures. I am a government employee from the Southern Philippines Medical Center under the Health Emergency and Disaster Management Unit. I have several trainings, but the most related to this topic would be from my MCM training, which I had last year. I had the basic training as well as the training of facilitators, and the content of my lecture is based from the MCM modules of my last year's training. So majority of my slides would be from the MCM training I had. My objectives for this lecture, so we will have a definition of terms. I think we can breeze through all of the terms because Dr. Convocar already had some of the terms discussed earlier. And then we will go through the discussion of the mass casualty management framework. And we will do the approaches to different approaches to mass casualty incident. And also we will discuss the system involved in the MCM. Mostly we will be discussing the field management as well as the rescue chain. So let's first define what is a mass casualty incident. Your incident is, I think Dr. Convocar already had mentioned the disaster. So the disaster and the mass casualty incident has a relatively similar definition. So when we define MCI, it is an incident resulting in a number of casualties. It may be dead or injured that is large enough to disrupt the normal course of emergency and healthcare services. Now, your administrative order number 2010 series of, 0029 series of 2010 on the policies and guidelines on the establishment of your operation center for emergencies and disasters, they define the MCI as an event in which the number of casualties, it may be dead or injured, is of sufficient magnitude to overwhelm your available resources of the facility or the community. So this has been explained further by Dr. Convocar this morning that it is subjective. The definition of a disaster or the mass casualty incident is subjective, depending on the capacity of the community and even the health facility. So we have two causes of your MCI, the natural, some of which, or an example of which, would be the mudslide, volcanic eruption, flooding, and typhoon. These are all enumerated by Dr. Convocar as well, and human-induced MCI, which are armed conflict, fire-induced, vehicular accident, and even stampede. So next definition will be the emergency services. Now, these services are specifically designed to respond on a daily basis to any emergency situations. So this will be police, the fire services, ambulance services, and even the emergency department. And healthcare services are now services providing healthcare to any kind of patient. So examples would be the hospital, the polyclinic, health center, the ambulance service even. So all of these services will encompass now your mass casualty management. So your MCM, or popularly known as MCIM, Mass Casualty Incident Management. Now we will shorten it for the sake of our discussion to MCM, Mass Casualty Management. This will be the management of victims of a mass casualty incident aimed at minimizing loss of life and disabilities. So we will now be going to the framework of your MCM. Now, the framework will be the backbone of the response and even the preparation of your services, the emergency services as well as the healthcare services. Now, to talk about broadly, the MCM framework will be mostly composed of your community response and even the preparedness. Now, the hospital services would come in mostly in the fifth step, which is the surge capacity. Now, steps 1, 2, 3, and 4 will be talking about the community-based response. So first step, there will be a community-wide preparedness and response. Now, if you would like to take a picture of this slide, feel free to do so, but please make it so that you are the only one using it. Do not share this to the social media. So your MCM net framework would composed of your community-wide preparedness. This will be the public or the local government unit will have to do their preparedness and training so that they will be having making their plans to reduce the vulnerability, to mitigate any hazards that they can identify within their community, and also prepare for emergency or even the crisis response. Now, for any given incident, for any given disaster, the responder would be any responder that can arrive first to the incident. So it may be the police, it may be the fire, it may also be the barangay emergency teams. No? So for any incident that may happen, consequences will be encountered. So the consequences would involve the people, the services, the environment, the economy, and even the infrastructure. So those would be part of your identification on how to go about or how to mitigate all the.
Okay lang. Thank you.
And these consequences
Sandali
would
lang
also
ako.
generate demands from the event per se. No? So your event-generated demands would include your warning alert, your search and rescue, your restoration of your essential services, and even the continuity of your operations, different operations within the community. Now, your responder may opt to activate your MCM system or may not. No, it depends on the capacity again of your responders to respond to a specific incident and even to control that incident. Now, if the incident has been controlled, he may opt not to activate your MCM, but sometimes even the small incident may escalate to even further chaotic incident. So that's why your MCM system is very fluid. It can be activated at any given time. So your MCM system would include your emergency operations center, your ICP, incident command post, the hospital, your EMS system, resources and staff, logistics and communications. And other components of your MCM would be the following things that is shown in the slide. Now, with your MCM system, demands now will be generated through your response. So if you have already identified what kind of services you need to do in your specific community or the incident, this will now generate different response demand, like your communications, the mobilization and redistribution of resources. So it may be a human resource. So if there is fire, you need to mobilize your fire protectors. And for control of the crowd, you may need your police. So when all of these resources, human resources, has been distributed, they need to have a coordinated mechanism, and then also delineate the authority as well as the incident command post. Then also identify what are the logistics needed and how to manage each of it. Now, all of these steps from 1 to 4 composed is mainly seen in your community problems or community environment. Now, all of these community steps would now present or go forward to your surge capacity to your hospital facility or health facility. Now, your surge capacity, it may be an urban or rural area, depending on what is the capacity of that health facility. So if it's only um, minor injury, then they can provide for their healthcare service. You can already send it to them. For further management, like for your burn patients, for your fractured patients, you may opt to refer to a higher facility. So your surge capacity we'll talk about later for the structure, the staff, and equipment. So further discussions about the surge capacity will be discussed by another lecturer this afternoon. Now, when we talk about preparation, especially in the community setting, there is always a pre-planning stage and a training stage. So these two are critical so that your mass casualty management would be efficient. So during your training phase, your planning phase, you need to establish guidelines and procedures so that your human resources would know what to do, when to be present, or when to be deployed on a specific time or a specific area. And also, I need to emphasize that early implementation of incident command system should be highlighted and should be appreciated so that your management, your services will not proceed to a more disrupted one. So again, I need to highlight that the first 5 minutes will determine your next 5 hours. So your outcome will be determined by your first 5 minutes. Now, we have different approaches to your mass casualty incident. The three approaches would be the basic approach, your classical care is the second, and your mass casualty management approach would be the third. We will just be discussing fast. So I think most of our participants already know about the different approaches. So the basic approach would be a scoop and run method. This is most commonly used to deal with accident victims, and especially for small scale accidents. Now, the advantage of this approach does not require specific technical ability for the rescuers, and there are lesser interventions from first aid rescue or rescuers. Now, the disadvantage of this approach would be your patients will be directly transferred to a specific health facility, and if it becomes overwhelming to that facility, this will now burden the hospital. And sometimes rescuers may add up to the injury of the victim. So that means since your rescuers doesn't have any specific technical ability or doesn't have any training, they may add to the injury of the patient. The second approach would be a classical care approach. Now, this approach is a more organized care for smaller scale incidents, and usually your rescuers have been trained to do certain kinds of services or maneuvers to give to your victims, like for example your standard first aid or even your life support, basic life support. The disadvantage of which is in a mass casualty situation, this approach will quickly result in chaos, since you only have two working agencies or two working organizations that is independent of each other. So sometimes or most of the time they have weak linkages between each other. So I think this will be also part of your hazard or risk identification, so that you can have your personnel to be capacity builded. Now, the third approach would be your mass casualty management approach. This involves training of various level of responders. So this means that your responders will have different kind of training. So your hospital have a different trainings for your personnel. The community has different trainings as well. The advantage of which is that it incorporates links between field and healthcare facilities. Now, this would be a more systematized approach. No, dependent. The disadvantage is that this approach is highly dependent on the availability of large number of human resources or even non-human resources. However, this approach is the most ideal approach to do your mass casualty incident management. So when we talk about mass casualty management, incident management rather, we will this approach is using the mass casualty management system. Your mass casualty management system is a group of units, organizations, and sectors which work jointly through institutional procedures to minimize disabilities and loss of life. So this system is a coherent and interrelated set of established procedures, policies, and plans within the community setting, so that your objectives are shared within different agencies, different personnel. They have only one system to follow, and this will be making your emergency response or your response rather to be more efficient, especially in your community
Biodegradable
setting.
liter ka.
Now, your mass casualty management approach is using your mass casualty management system, which is based mainly on the multi-sectoral preparation and response, and during which your multi-sectoral preparation and response, you will now be able to formulate a strong pre-planned and tested coordination with other agencies. Pre-established procedures is also established here to meet the demands of a certain major incident. So as I've said earlier, there is a specific training of various levels of responders to maximize your existing resource, your logistical problems and resources. Now, all of the agencies, the system incorporate links between field and healthcare facilities through an emergency operations center. So this emergency operations center is another thing to discuss about later, or maybe probably this would be another topic to discuss about in the future setting of future discussion. Now, talking about MCM or mass casualty management, the field management as well as the rescue chain, which is your surge capacity, and it will be discussed further by another specialist. So your field management encompasses procedures used to organize the disaster area in order to facilitate management of victims. Now, to your right, you can see the CSCATTT. Now, this is uh, the method used or the format used of the British emergency services when they do about their field management. So your field management should compose of your alerting process, your pre-identified field areas, safety, ICP or your incident command post, search and rescue, field care, evacuation or transport, as well as your EOC. Now, all of these components will be seen here with our CATT or CSCAT. So the first C will be command, C communication, A assessment. That the remaining three T's would be your triage, treatment, and transfer. Now, all of the things mentioned or enumerated here would have a separate lecture. So let's just move through to our next slide, which is the alerting process. Now, your alerting process is a sequence of activities implemented to achieve the efficient mobilization of your adequate resources. Now, usually your field management in an event or in an incident, this will be the first or the start of your MCM, your alerting process. So the first responder will be the one to alert your EOC. Now, this will include the initial assessment to confirm to evaluate the extent of the problems, as well as to ensure the appropriate resources to be mobilized during that incident. So again, the British Emergency Services use the methane method rather. So methane will stand as M for major incident. So M, if the incident is a major incident or a minor incident. If yes, then you can proceed. If no, still you can proceed, but it is a lower scale response. Next, we need to do, or we need to establish the exact location of that incident. So the geographic area, probably the ones who are very much attuned to their location would be the residents of that location. So the responders may opt to ask the residents for that specific location. And then T would be the type of incident. Is it a vehicular incident? Is it a fire incident? Or is it a structural or fall or a collapsed building incident? And then that responder would need to identify hazards, potential hazards that can cause more problem or that can escalate the incident. So say for example, the fire, so we need to address fire as well as the people. Those are some of the examples of hazards. Now access, the letter A, what are the best routes or the best routes to access your incident. So you need to inform your EOC the ingress of your medical service to avoid traffic in your area or congested traffic in your area. The N would stand for number of casualties. You need not to identify or specify a number, but just estimate what is the magnitude of the casualties identified in your area, or the last letter, the letter E. So all the PNP, you need the police to control the crowd, we need the fire brigade to control the fire, and etc. Okay. Now, your alerting process has a role, or the dispatch center, so to say, the dispatch center. They have a core in the operation and receives all the warning messages via the radio or the phone. And they are also the ones to mobilize a small rapid assessment team, either from the police, from the fire, or the ambulance services. Now, your EOC, or your Emergency Operations Center, is your central communication hub and coordinates for the needed logistical requirements of the incident. So if necessary, multi-agency is also needed for your EOC. Now, your EOC differs, just a thin line of difference with your alerting or your dispatch center. Now, in Davao City, the most common agency for a dispatch center is the 911. Now, EOC would also encompass that dispatch center and also include your DOH region, the local government units, and even your hospitals. So each of those agencies would need to establish their own emergency operations center, so that they would have a singular communication system to pass all the logistics needed for that specific incident. Now, your first responder, once in the field, need to have identified some specific areas to put up different kind of service or tents. Areas need to be put up, like for the impact site. Identify where is that site involved, and then identify also the incident command post, where to put your ICP, where to put your casualty collection point, your advanced medical post, your evacuation areas, the press area, especially the press area, and then access roads, and even the checkpoint for resources, which is your staging area. I think down the line, we will be discussing some of these with the following slides. Also, your first responder should also need to identify safety problems or safety points. This is a best practice technique to protect your victims and even your responders, as well as your exposed population, to an immediate or potential risk during that disaster. So your measures would include risk reduction, especially in the fire. You need firefighters. If needed, to contain your hazardous materials, you may also need to mobilize your CBRN specialist, and also your evacuation areas for your exposed population, as well as to secure those population from the disaster or impact area. Now, your safety would include 3 zones. This will have the primary zone, or the impact zone, or hot zone. So just to simplify and have a common understanding for all, we just use the hot zone. So the hot zone is where your rescue comes in. The second zone, we call it the secondary zone, or the warm zone. This is only established when there is a need for decontamination within the area. And the tertiary zone, the buffer zone, or the cold zone. This is what we commonly known as the cold zone. This is where you put especially your media, your ICP, your AMP, and your CCP. Now, your ICP will be discussed. There's further in discussion with the next lecturer. We'll just have a broad discussion here. The purpose of your ICP is for coordination and communication, so that there will be an efficient management of your resources for different needs of the incident. Now, the location of your ICP is at the cold zone and should be accessible and easily identified by the people as well as your responders coming in for further uh, additional management. Your ICP must have all the communication capabilities such as your maps, your boards, and even radios and cell phones. No? So your ICP is like your EOC as well. This can also be your EOC actually on the field. And then other areas, we have the search and rescue. The search and rescue is in the red zone or the hot zone. This is where the victims are located and removed to be placed on a casualty collection point. Now, this is where the triaging start. So the triaging, we have different kinds of triaging. So in my discussions further, I will be mentioning the triage that we used during our training. But there is no hard and fast rule to what kind of triaging you should use. But I think the emergency medicine also have their own triaging system. So in the search and rescue, there is a specific triaging system, the very fast one. You need to triage the victims in a fast manner in less than 10 seconds, most ideally. And also, if it may be also the zone where you provide your first aid, especially for bleeding. Now, always remember in the hot zone, there should be no CPR on site in the MCI. Now, your progress to the pre-hospital emergency and disaster medicine, this is an established AMP, your advanced medical post, which is composed mainly of your medical teams. They are specifically trained for that kind of disaster. And also, you should have communication between the field scene and the medical facility. So I forgot to mention that there should be a team leader which always carry a communication device to refer your collected patients to the next area, which is your casualty collection point. Your casualty collection point will have to have a team leader as well, equipped with your communication device so that they will also communicate to the next area, which is your AMP. Now, your CCP will have another triage system to use. Your AMP will have another triage system to use. Now, I also forgot to mention the CCP. In our training, we had the Steve triage system. It is a combination, as to my understanding, the combination of a START and a SIEVE system, triage system. Now, the AMP, we make use of the SORT system, the SORT triage system. It's a system mainly using different scores so that you will have a different triaging priorities to your patient. Since your patient is mainly triaged in a color assigned priorities. Now, next area would be the evacuation or the transport area. So your AMP should be next to a transport area so that your patients needing the transport, your red tag patient should be transported first. This is to facilitate transfer of the stable patients to a specific health facility. Now, this will be headed by your transport team leader, also equipped with a communication device. Now, remember, I think Dr. Convocar already mentioned that your disaster should not be transferred to the hospital. So remember that the basic approach, scoop and run, the victims are transported directly to the hospital. Now, if you transport vast number of victims to that hospital, it may transfer the disaster to that specific hospital. So it is important to also to identify not only one hospital but several hospitals so that the hospitals will not have the will be able to cope for the number of patients coming in. Now, talking about rescue chain, so that you will have a better understanding of an overview of what I have been talking earlier. The rescue chain is the essence of your mass casualty management system and involves several sectors. So the sectors has already been mentioned earlier: a skilled multi-sectoral rescue team, a basic radio communications network, an efficient admission and emergency department, as well as a coordination procedures among all sectors involved. Now, we have two rescue chains. The first one would be under a stable condition. Now, your hot zone will be the impact site. So this will be the start of any incident or any mass casualty incident. From the hot zone, you have personnels there for your search and rescue, for collection. So once you have collected, there is the triage system used there, and then transport your patients or your victims to the casualty collection point. There will be another triage system there to move to your advanced medical post. Now, your casualty collection point is now part of your cold zone. But remember, this is also the pre-hospital phase before you transport your patient to the hospital. Now, the cold zone will be where your ICP is located, your AMP, as well as your staging area. Your transport services will be part now of your pre-hospital as well as the hospital setting. Your transport may include the land services, your air services, and your sea emergency services. So that your endpoint, always endpoint of your victims, will be the hospital. The other rescue chain will be the unstable condition. The difference here is that we will now need to put up your decontamination area. Your decontamination area will then be your warm zone. So from the impact zone, the hot zone, your victims will now be transported for a decontamination. This will be uh, usually used in a CBRN or your chemical burns, radiologic, and even your explosives of part of your services. So the remaining of services will be services would continue up to the end of the hospital. As in any chain, the strength, and if one fails, the entire system will be compromised. And with that, thank you for your kind attention. I end my lecture.
Dr. Corticos, thank you very much for a very informative lecture. MCI is difficult to grasp, but you were able to beautifully present it to us in a matter of 20 minutes. So thank you very much, Dr. Corticos. At this time, we are open for questions from the floor, also from on-site and from both online. let me just ask you quickly, Dr. Porticos, can you elaborate more on no CPR on MCI side? I think a lot of us reacted to that. Did you mean the hot zone, at the hot zone area? Dr. Porticos? I think he's not online at this time.
I'm sorry, Dr. Ray. I lost the connection. I only got the no MCI.
Yeah,
Then it
Dr.
was cut off after.
I'm sorry about that, Dr. Porticos. We're having some interruption with the internet connection. Again, the question was, would you like to elaborate further on the dictum no CPR on MCI? Did you mean no CPR at the hot zone?
Yes, that's correct po, Dr. Ray. So
Yeah.
it means that your patient should be transported away from directly away from your incident viewers as well as your victims is now established.
Yeah. Okay. So the pre-hospital care will definitely include the staging area at the hot zone, no, the extrication area at the hot zone, and then proceeding onto the warm zone, and then the cold zone. And then it ends with the transport of the victims to the hospital. Am I correct? Am I correct?
That's right po, Doctor. But then it is the hospital is still part of your MCM system.
Okay. Anyone from the floor or on site and online that they can now ask your questions? You can send it through the chat box. Dr. Francis, may I ask you, what is your experience in Davao with the 911 system? That actually this is a model system for the entire country. So how do you the incident in Davao? Who goes first, and who should be the incident command post?
And now you're actually in the 911 system. I'm sorry, I'm not that familiar with the 911, totally familiar, but the 911 is usually the number called, and they are the first ones to be mobilized, the emergency services. Now, your 911 will have to inform other services that needs to be mobilized, especially if a specific incident has occurred, like a fire incident. So your 911 will not only mobilize your emergency services, but mobilize the firefighting services as well. Now, when it comes to the incident command, the first responder command, the incident commander rather. Now, this incident commander will then identify what needs to be done or what services would be needing. And as the incident escalates, your incident commander will also be evolving.
Okay.
So
Thank you
it
for
may
that.
be from the responsibility to a higher.
The 911 system in Davao, you still have your one hospital command center, right? The one hospital command center. So I would presume that they are working hand in hand with the 911 system, or they are two different entities.
Now, the One Hospital Command System is under the Southern Philippines Medical Center po, Dr. Ray. They are working hand in hand. No, they are communicating and coordinating together. So, OHCC will have to calls on all the referrals from the 911 also.
Question.
Dr. Ray.
So for Jensen, actually, we are still moving towards that. With Dr. Section Kabatay here, I think we had a small talk, over a dinner with the Chamber of Commerce, because we really want to start our own system, whether it's 911 and the one hospital. The one hospital command actually has been relegated to the city health office, and I think we are working on that. We had one consultative meeting at Sangguniang Lungsod, introducing the one hospital command as mandated by the Department of Health. We need to establish that. As to the 911, I think we are still in talks with that, because this system definitely requires a lot of resources coming from
Yes,
both
that's right.
private and the government sector. If the government and the private sectors will work together hand in hand, that would be the best. Since our current president of the Chamber of Commerce is very active on this one, we are seeing a glimmer of hope that probably we can jumpstart the project, and we badly need this one. So again, Dr. Porticos, your 911 system is our envy. Dr. Ben Valdez, I spoke with him shortly, months ago, and I already asked him for his help, because he is, I may be correct, he's one of the authors of the 911 system in the world. And he's still with you, Dr. Porticos, right, with SPMC?
Yes, that's right po, Doc. Yeah, Dr. Ben is still the
Yeah.
part of the consultant in the OHCC.
Yes. Okay, Dr. Convocar, I guess, has a comment here. The One Hospital Command Center has now evolved in patient navigation and referral system. So this is now the new name, the One Hospital
Yes, that's
Command
right.
Center. Okay. All right. So I guess with that, Dr. Francis, thank you very much. Sorry.
Thank you.
Okay, if you may stay for a while. At that. Okay. There is a question here, Dr. Porticos. The question was,
Yes.
at the hot zone, how can we activate the triaging system while so this is a pre-hospital part of the pre-hospital care. The question was, how do we activate the triaging system? In relation to that, which is the most efficient triaging system that you have used so far? Is it the SWORD? Is it the START? Okay.
Now, actually, for that question, it will not be mainly. I will not be recommending a specific triaging. They will train to a different kind of triaging strategy. But in our training, we use the STIV triaging system. So it's a combination of the START and even the SIV. The most important thing is that you need to identify if the patient is still alive or not. No, so if the patient is still alive, the next would be, is the patient still breathing, right? So that, I think that would be the most efficient use of your triaging system is to use it under 10 seconds for each of those patients, especially in the hot zone. Now, if we can use the different triaging system under 10 seconds, no problem with that.
Yeah. The idea is to extricate the patients in less than 10 seconds, move them to a safer
Yes.
side. Yeah.
Safer, yes.
From the academy, from Mindanao State University, General Santos City. Doc, do you recommend that all colleges and universities have their own rapid team, fire brigade, and ambulance? Or does it depend to their population and access to hospital?
No, that would be the most ideal po. No, the colleges and the universities would have their own rapid emergency services, so that they are the ones, the first ones to arrive or even to assess that kind of incident if needs further resource mobilization and even further escalating it to a higher institution, to a higher authority. We had one training before. We trained a specific part of here in the region, a specific college. No, their feedback would one of their feedbacks was they really appreciated the system and would like to apply the system to their school also. Cannot I cannot disclose what school was that.
Yeah. Well, ideally, if an organization has a lot of population in it, it would be best that they have their own disaster response system. Okay. Dr.
Yes,
Convocar was commenting also on the triaging done in the red zone. She said that there should be no triaging done in the red zone. Triaging happens in the yellow zone, or sometimes referred to as the warm zone, which is what we emphasized a while ago. Yeah? So we move the victims or the patients
away
to a safer zone before we do the triaging. So fast extrication from the hot zone, what is necessary initially. So I think, do we have any more questions from the floor? Dr. Na, did we answer your question? Yeah. Okay. And another one? Wala na.
Doc, my
Okay.
question
So
po, Doc.
Dr. Convocar said, agree. The better term to be used is extrication from the red zone, since the red zone is a danger area. Yeah. Okay.
Doc, excuse po.
Pauline, would you like to say something?
Kasulod.
Dr. Convocar?
Yes, Dr. Ray, can you hear me?
Yeah. You are recognized, Dr. Convocar.
Yeah, thank you. There are a lot of raised hands, and congratulations, Dr. Francis, for a very excellent presentation. Yes, there are different triage systems used for every phase of care,
Okay.
and I just would like to.
While waiting for Dr. Convocar, I think there is another question from Emishu Jensen. Are you raising your hand? Would you like to speak?
Sir, good morning po. Sir, narinig po ba?
Yeah. Loud and clear. Go ahead, please.
Actually, sir, nagkasama tayo sa Migrant Summit. Francis Santopina po from the Mindanao State University. Actually po, isa din po ako sa responder. And yes po, nagagamit din po tayo ng triage sa red zone, pero reverse triage po, yung mas marami tayong masasave. Ang tanong ko lang po, sir, is lately kasi mayroon kaming na-undergo na seminar. Applicable po ba yung RTS dito instead of GC Jensen? Yung revised triage score, sir po.
We didn't get the question correct. Can you state your question again? Are you asking about the reverse triaging at the red zone? Is that what you were asking?
Sir, yes po. Ginagamit pa po ba ngayon yung reverse triage score instead of GCS?
Dr. Perticos?
No. For the reverse triaging score, the triage score, for our training, we still use the GCS, but it is under the sort triaging system already. Now, I may not be able to answer you correctly about the reverse triaging, but in our training, the sort triaging system still uses the GCS scoring, but this is applicable only in the cold zone already or the patient to the hospital.
Okay. Mr. Francis Antipino of MSH, is that clear? Okay. Follow-up question. Dr. Pauline, did you say something? Loud and clear. Okay, thank you. So I guess I guess that's all for the question and answer for Dr. Francis Porticos. Another message from Dr. Pauline: respiration, perfusion, and mentation, just AVPU. It's not GCS. So she just wanted to clarify that instead of GCS, we're actually doing a faster, assessment, which is the AVP.
Assessment.
Alertness, verbal output to pain or to no response. So, as a fast way of assessing patient at the bedside. Okay, so Dr. Porticos, any last few message for the group? Are done?
Actually, the MCM is very broad topic talaga, Doc. So I really tried to compress the expansive topic to just 30 minutes. So if there are more questions, you can send away questions through the email or to any contact details that we will be sending.
Yeah, we will be forwarding to you some of the questions because I think there's a lot of things that to grasp at this time. Where MCI, like I said, MCI is a very broad topic. It's difficult to deliver everything within 20 to 30 minutes. So we'll just forward it to you as they come. So thank you very much, Dr. Porticos.
Thank you also, Dr. Ray.
Spending your time with us this morning. Okay, so let me just present to you our certificate of appreciation. Okay, Dr. Porticos, on behalf of the Dadiangas Medical Center, in partnerships with the Philippine Medical Association, GSCCI chapter, and the Philippine College of Emergency Medicine, I'd like to present the certificate of appreciation to Dr. Francis E. Porticos, MD, FPS, MSGS, for his valuable contribution as speaker on mass casualty incident response in the Scientific Symposium on Disaster and Emergency Preparedness. Given this day, the 2nd of April, 2024, at the Dadiangas Medical Center, Multipurpose Hall, Leon Led Street, City Heights, Jason, the city, signed by our Medical Director, Dr. Eva Baday Sarmigos, and the PMA President, Dr. Japit O. Galagaran. Thank you. So moving on to our next topic. Can I stop share? Right. So Dr. Dan Carper.
Good morning.
On board now? Okay.
Okay, good
All
morning.
right, so let me reintroduce to you our next speaker. He's a graduate of Bachelor of Science in Biology at De La Salle University in Dasmariñas, Cavite. He's a Doctor of Medicine finished his formal training at De La Salle Medical and Health Sciences Institute, College of Medicine in Dasmariñas, Cavite, and also did his masteral in hospital administration at the College of Public Health, University of the Philippines, Manila. He is currently an emergency medicine specialist at Hospital ng Makati. Is a fellow and a fellow of the Philippine College of Emergency Medicine and a diplomate of the Philippine Board of Emergency Medicine, and is the president. He was the president of the Philippine Association of Residents in Emergency Medicine, or PAREM, during his time. Currently, he is affiliated with Mandaluyong City Medical Center and Santa Rosa Hospital and Medical Center. Ladies and gentlemen, here to talk about Incident Command System, let us all welcome Dr. Daniel Carpio.
Okay, good morning, everyone. Okay na yung audio. Good morning.